I've done a lot of work developing liquid biopsies or testing of the plasma cell-free DNA. And this is because it really comes from the fact that tumor biopsies are inconvenient for the patient because they're risky, for the doctor because they cause delays and they're frustrating. They're inconvenient for the pathologist sometimes because the specimen's too small and it doesn't work out. And so there is a need, an urgency to get answers back quicker when possible and more efficiently. We did a study where we showed in patients who got a blood test as well as tumor testing, the blood test took on average 3 days, and the tumor testing for resistance, let's say if you ordered a new biopsy, took on average 28 days. I mean, dramatically different for an advanced lung cancer patient. And so we've now used liquid biopsies increasingly as an early screening test to look for a key mutation. If it's present, you can act on it. If it's not present, you can't trust the negative result, you go to biopsy. And that's because a positive test is generally reliable. It has a high positive predictive value. There are a few false positives. But a negative test is not reliable. The sensitivity is not that great. It's maybe in the range of 70% for advanced lung cancer. So we send it at a moment where I'm trying to make a decision. I'm looking for an EGFR mutation. I'm wanting to start a targeted therapy. I send the blood test. Result comes back often within a week, which is great. I mean, certainly faster than ordering a biopsy. But if it's negative, I then proceed with biopsy. And so how to integrate that into our paradigm increasingly, I think is challenging. You know, for my patients, they come with newly diagnosed advanced cancer. I'm not sure of their genotype. Maybe their tumor biopsy is used up, or it's far away, or it's scant, or was small. I'm not going to get tumor NGS. And I say, ugh, do I get a biopsy and get the tumor NGS running? I mean, they're sick with stage 4 lung cancer. They're symptomatic. Wait, I send a blood test and I start treatment. And then that plasma next-gen sequencing maybe will come back a couple weeks from now as treatment's going along. And if a treatment's going well, I may not need it. But if a treatment's not going well, or if they recur and they're going to progress at some point, I have this genomic data as a backup plan, as my alternative to an empiric initial therapy. So it does require some nimbleness for doctors to figure out how to build these diagnostics into their care, but it really fits the need because of the frustrations of getting biopsies and the delays involved in getting tumor NGS in some situations.
Yeah. I think there's a lot of instances which liquid biopsy could be very helpful. You touched on them briefly. The specimen inadequacy is something that we deal with, very, very common, especially in lung cancer biopsies. They can be very scant. And if the patient, perhaps they've been to multiple institutions and multiple people have ordered immunohistochemistry and there's very little tissue left. And perhaps the patient is too ill or there's not a great, way to get another biopsy. So I think that's a really excellent opportunity for liquid biopsy to make a big impact in patient care and kind of in this turnaround time issue as well. At our institution, it's mostly used right now looking for resistance mutations. And then it's the most common way it's kind of ordered, and this is a test that's being sent out. We haven't offered it clinically yet. And then occasionally, if there are no other material available, all the material is gone or has been used, and that can be more in the first line setting.
Targeting resistance is something we're increasingly doing. We do it for EGFR, where we have mutations that lead to other therapies. We do it for ALK, where there's increasing data that ALK resistance mutations lead to other therapies. There are MET resistance mutations. There are ROS resistance mutations. Each of these are opportunities where you say, oh, I need a new biopsy. Gosh, if a blood test could get me this answer quicker, it's good for all involved. And so it's becoming certainly that initial pass blood test before a biopsy for resistance. It's worth remembering that the mutations in the blood, though, are not just tumor mutations, right? There are mutations in there that are the patient's germline mutations, right? So you can stumble upon a BRCA mutation in your report, and it's actually their germline mutation, definitely possible. There are white cell mutations, okay? So clonal hematopoiesis mutations, P53 mutations that are just age-related or chemo-related that sit there in our white cells. They shed into the blood, they pollute the DNA. So this is not a biopsy. This is not a tumor biopsy. It doesn't really replace tumor biopsies. It is a shortcut, a convenient insight into the tumor biology, but you need to take it with a grain of salt because it really is not tumor genotyping. It's not ctDNA analysis. It's not tumor DNA, right? It's just a potpourri of mixed DNA you're looking at, hoping to see what the tumor's like by testing this plasma DNA.